Hi, Dr. Raj here, and today I'd like to talk about treatment-emergent central sleep apnea, and it goes by the acronym TECSA, T-E-C-S-A. Now, before I go diving into it, I want to take a step back and talk about central sleep apnea to begin with. It's not common. So if you come across that on your board exams or in clinical practice, you always have to ask the question, why do I have central sleep apnea? And treat the underlying cause. Could it be from heart failure? Do I need a transthoracic echo to look for that ejection fraction? If it's less than 45%, this patient should not be treated with adaptive servoventilation. That's associated with poor outcomes on those patients. Do I need to get an MRI of the brain and look for an Arnold-Chiari malformation? Should I worry about drugs that induce that central sleep apnea, such as opioids? Or the big one I want to tell you for your board exams are oxybates. Yes, I said oxybates, the medications that treat narcolepsy, whether we're talking about Xyrem or Xywav, or even the extended release oxybates, they can make central sleep apnea worse or induce central sleep apnea. And of course, think about neuromuscular disorders and high altitude. But now, based on the history, based on reading the vignette, you know it's going to be those treatment-emergent central sleep apneas, focusing on someone getting CPAP. I used to see this all the time. Why? We used to do a lot of in-lab polysomnography, and we'll do a split night study. I'll do a full night titration. And what do I see? That as we're increasing the continuous positive airway pressure, the obstructive apneas and hypopneas go down, down, down. But all of a sudden, the central apnea index goes up. And when you're having those central events, more than 5 events per hour, I am worried. So when we're actively seeing it during those in-lab titrations, what do I tell my respiratory therapist to do? Don't go higher on the pressures and maybe just do nothing. Sometimes, if it's indicated, we'll switch the mode of positive pressure to a bi-level device with a backup rate. We call that ST, spontaneous and time. Or sometimes we may use adaptive servoventilation if they have a good heart, EF greater than 45%. But I want to talk about why, when you give CPAP, do you induce these central apneas? There are 2 main concepts behind it. Number one, maybe you're blowing off too much carbon dioxide because you're anxious, you're just putting a mask on your face, maybe you're kind of hyperventilating a little bit. And on top of that, we're giving you positive airway pressure, which is also contributing to blowing off too much CO2. And if you blow too much carbon dioxide off, you're not going to breathe. That's central apnea. The other concept is called the Herring-Brauer reflex. What is that? That's going to be a protective reflex in your lungs. They're located in the bronchioles. They're stretch receptors to make sure you don't get too much air in your lungs when you're breathing in, causing volume trauma. So what happens? What's cause a central apnea? You're giving positive airway pressure. You're stretching out those bronchioles. The pulmonary stretch receptors like, wait a minute, stop taking a breath in. So it sends signals to the brainstem, specifically the medulla and the pons, to tell you, stop taking that breath, hence central apneas. So what do we do with this CPAP-induced central sleep apnea? Well, number one, do nothing. Probably going to resolve on their own. So let me give you some numbers that when we talk about treatment-emergent central sleep apnea, it happens in the range of 5 to maybe 20% of cases. I think the sweet spot is around 10% of cases. Now, those 10%, 2/3 resolve on their own. But as I mentioned earlier, you could think about using a BPAP with a backup rate. You could think about using adaptive servoventilation. But most of the time, we do nothing. And what is my last pearl that I want to tell you is that there is a reason why it's called treatment-emergent central sleep apnea, because multiple therapies for obstructive sleep apnea can cause this, including tracheostomy, including surgeries, which include the classic things like the UPPP, the uvulopalatopharyngoplasty. It can actually be caused by the hypoglossal nerve stimulators. I think the brand name for that is like an Inspire device. It can do it. It can happen through mandibular advancement devices, those dental devices. And of course, traditionally, it even happens through CPAP. So I really hope you enjoyed this encompassing talk of what we call TECSA, Treatment-Emergent Central Sleep Apnea. It will be on your sleep medicine board exams.